everybody, Priya, for that excellent talk. So I think we're going to take some questions now. So we've got some questions online, and we'll start with any questions from the floor. Imran?
Thank you for... Can you hear me okay?
No?
I can now.
No.
Better now.
Thank you for the brilliant talk. This could be for any of you, because looking at the first slide that you presented, Dean, Homer Simpson, I think, has got alcoholic liver disease and NAFLD. So what's the diagnosis for these individuals? Do we say both alcoholic liver disease and NAFLD, and is their prognosis any different to individuals who have just got alcoholic liver disease or NAFLD, if that makes any sense?
I mean, home is my slide, so I could start. The answer is you can have both NAFLD and alcoholic-related liver disease. Usually the alcohol-related disease takes precedence because alcohol-related disease has the highest impact in terms of liver disease-related mortality. But the important thing to remember that whenever you've got, as Priya mentioned, whenever you've got two things causing liver disease, they have a kind of synergistic effect. So the progression to fibrosis is much, much higher in those who are obese and who drink excess alcohol than either those who drink excess alcohol or those who are just obese. So it's really important. I mean, because both things require lifestyle intervention, you tell them to stop drinking and to lose weight.
I agree with Dina on that. I think what I tend to do in that situation is focus on the alcohol more. And actually, it's a really easy win, isn't it? If you cut your alcohol, you're cutting your calories, which might help them lose weight. And I sort of go down that line with them.
The only caveat is to remember that there is a huge amount of malnutrition related to obesity and to alcohol. And so you need to be very careful when you're giving them dietary advice that they maintain good calories whilst cutting out bad calories.
So there's just one question, actually, and I don't know who wants to take this, because I'm afraid it doesn't sound like it's going to be for any of you guys, but can the Sheffield consultants advise the Sheffield GPs here of the pathway we should use for NAFLD, please?
So, as the sole Sheffield hepatologist here, that's a very, very good question, and that is under development now. So I don't know if anybody uses the ERS system. There is a template up there now which hasn't quite gone live, but that will be happening very shortly, along with some quite definitive NAFLD guidelines as well. So it has been in development over the past year or so, and it's almost ready to kind of go online. But I have to say already there's very high quality of referrals from primary care for the NAFLD service. So the impression I get certainly is that the GPs in this region have a pretty good understanding of when to refer and all the tests to do beforehand. But there will be very clear guidelines coming out probably in the next 6 months or so.
Hi, I'm Rose. I'm the liver nurse at Rotherham Hospital. My question is, once I refer people for liver transplant, that's it, they're kind of out of my hands. And I am aware that obviously alcohol liver disease patients, they have to achieve a certain amount of abstinence before we can refer on. But I'm just thinking regarding NAFLD patients, to prove that they've made lifestyle changes, do they actually have to have a specific amount of weight loss before we can refer for transplant?
I think that's a really good question. Again, it's been under debate, and it's something we talked about in our last transplant meeting. One of the major issues is the surgical technicality about whether or not they can be transplanted. In our unit, at least, we're using a BMI cutoff of 40. I'm not sure what Birmingham are doing there, but for us, it's a BMI of 40. And we did talk about, actually, if their BMI is above that, just like we do with patients who've got alcohol, trying to get them to stop and to show commitment to stop. We should be doing the same with people who've got a BMI above that and showing that they can and will be motivated to lose weight to try and reduce their post-operative mortality and risk.
And it's the same in Birmingham. It's a cut-off of 40, but the dietitian plays a huge impact on that MDT approach to decide who to list. And if they're not showing engagement or any improvement, it will be detrimental to them.
And the other thing to mention in Sheffield is we have about to start a new dedicated multidisciplinary NAFLD clinic, which involves a NAFLD nurse, a dietitian, and hopefully a physiotherapist, where it'll be kind of a one-stop shop where they come and have blood tests, a FibroScan, lifestyle advice, dietary advice, and so hopefully the referral pathway for that will be up and running pretty soon as well, so it'll be quite a good service. There's one question I wanted to ask you guys which kind of pertains to that really. It's to do with the sort of scoring systems and in terms of primary care, how to refer in. And you mentioned about the FIB-4 score, but also the NAFLD score. And one of the sort of paradoxes that I've kind of come across in the past is that nearly all of these scores, certainly the NAFLD score, and I think the FIB-4 score, if you go back and look at the original papers, all of the cohort for the NAFLD score, I think it's 470 odd patients, they all have abnormal LFTs. And so strictly speaking then, these scores are not valid in patients who have normal LFTs. Yet we also know from your work in the Scarred Liver Project in Nottingham and so on that there's a significant proportion of people with normal liver function tests who will still have significant liver disease. So what thoughts do you have about how do we incorporate that into our referral pathways really, because often we get referrals from GPs where the LFTs are completely normal and yet the FIB-4 score is the NAFLD score is intermediate or high, and they most often don't have any significant fibrosis when we do FibroScan.
I think that's also a really good question. You're right, the original papers were completely on abnormal LFTs. They have been subsequently repeated, and there have been studies showing that they've been validated in patients with normal liver function tests. And I think we've just got to be as pragmatic as we can and use it in a stepwise approach so we don't use it as a single, yes, they're abnormal, absolutely, they've got advanced fibrosis, and just make sure we've got second or third line tests to follow them up.
I don't know if this is something that's going to change, but I know there's been debate about whether the cut-off values for ALT and AST are too high and whether they should be coming down. So
similar to the Hep B cut-offs that we use, yeah.
We might see a change.
Okay, any more questions? Kumar?
Can't hear my mind if I use mine. So, I mean, there's a striking inequity, isn't there, in deprived areas versus well-to-do areas in terms of mortality. Is that related to nutrition being a protective effect? And I guess my question is, how do you see the next few years going when it's heat or eat? You know, there's another hit coming for liver disease. My second comment is more of a personal nature, is coffee reduces risk of cirrhosis. Is that decaf or normal caf? And do I need to change back to caffeinated?
Do you want to take the first one, Dina?
I don't mind taking the first one. So yes, it's very striking. So even though people who are more affluent drink more, it is the poor who are more affected by liver disease. And that's probably for a combination of factors. So nutrition is a really, really important part. So generally speaking, those who are more socially deprived choose between drinking and eating, whereas those who can afford to do both. And also there are other factors such as their housing situation, their employment situation, their comorbidities in terms of mental health, the patterns of drinking, that all have an effect on causing increased harm in that group of patients. In terms of the effect of the pandemic and what's likely to happen over the next few years, I think it's very, very scary. So, as I said, even in 2020, where, I mean, we wouldn't really have expected to even see the start of the effect of people's poor mental health and their increased drinking habits having an effect. There was a 20% increase in alcohol-related deaths, and I would expect that to continue to rise, particularly when people can even less afford to eat, but can still buy very cheap alcohol. And that's why I think we really need to work hard on minimum unit pricing and the other policy changes that might be able to make a difference, as well as obviously, I mean, tackling the wider social situation and cost of living crisis.
I think following that up, well, even before I get to coffee, it's a similar issue, isn't it? It's actually cheaper to eat unhealthily than it is to eat healthily. And those two things go hand in hand. So you see a sort of, just like you do with alcohol, you see a rise in obesity and things like that in more socially deprived areas. So I think you're right, we've got a horrible hit coming towards liver disease. With regards to coffee, I think the studies were actually caffeinated, so I'm afraid you may want to consider swapping back, but less milk.
Okay, thank you very much. If we could just thank the speakers again this afternoon for some excellent talks. Thank you very much.
Hey, so I hope you've had a fun day. Dina, Priya, Nasser, thanks so much for travelling, and thank you for effortlessly giving really excellent talks. So we are drawing to the close of the symposium, and we usually like to have a state-of-the-art lecture, and by definition, a state-of-the-art lecture doesn't take questions. So if you look at, we are living through a kind of one moment where, you know, your grandchildren or someone are going to say, were you around during the pandemic? Just like I asked my grandparents about the World War. And it's all been quite doom and gloom today, hasn't it? Alcohol, dreadful things happening, Boris is useless, Putin wants another world war, Priti Patel wants to take us all to Zimbabwe. You know, the world is a bit crazy. And for your interest in terms of quality of life studies, you're at your most unhappy somewhere between the age of 45 and 55. So keep that one in mind. But this state-of-the-art lecture is done by Tim Williams, who is a local GP, a homegrown University of Sheffield graduate in 1996. And the reason I'm saying this is because Tim is still smiling. I've given you all doom and gloom, but I spent an evening with him yesterday, and I thought, this is a man who has some secret that I'm interested in. And so his title of the talk is, Does the Doctor Still Know What Is Best? Tim.
Thank you very much. Well, we didn't know best in the 1920s and 30s. And I still think we maybe don't know best now. So my name is Tim Williams, and I'm a GP by training. I've been a GP for around 20 years, and I also work as a professional life coach. And for those of you who don't know what a professional life coach is, it's someone whose life is perfect, and people spend time with them so they can be a bit like them. That's how it is. Okay, it's not like that at all. So a life coach is someone who provides exactly the right environment for someone to think really well about their own lives. And as a GP, what I want is for my patients to think really well about their long-term conditions and what they're presenting with, and to live a healthier life. And I suppose what I want for you this afternoon is to think really well about that question of, does the doctor still know best? And think, and maybe reflect on, is that the paradigm that we want to still be living in, and what has that delivered to us so far? But before we go much further, let me just ask you this question. In an ideal world, who makes the most important contribution to successful outcomes in long-term conditions? Okay, is it the patient themselves, or is it the health and social care system? So by show of hands, where do you think it is? If you raise your hand if you think it's all about us. If you think it's all about the health and social care system, we're the ones who make the biggest contribution, apart from David, okay? And let's maybe come half and half, a little bit further along the line. Raise your hand if you think it's a bit of a partnership, bit half and half. We do a bit, they do a bit. Few more hands in the air. And what about if you think it's more to do with what the patient does for themselves? Okay, a few more hands going up there. Okay, now raise your hand if you think about the current situation. Is this where we are right now? So raise your hand if you think the patients are making the biggest contribution right now. Okay, maybe raise your hand if you think it's a bit 50-50. Okay, a bit of a partnership, thank you, one hand at the back. Put your hand up if you think it feels like it's all about us right now. Okay, most of the people in the room. So this is the current situation, and yet this is what we think is most ideal. Okay, so we're here and we want to get here. So what do we need in order to get there? What do our patients need in order to look after themselves? Well, probably what they need is confidence, knowledge, and skills. If we want to look after themselves, that's probably what they want. It's not just knowledge, by the way. Knowledge is important, but it's not the whole picture. Informing people about their condition, it does something, it's useful, but they need more than that. Okay? Now, I want people to take responsibility for their health and well-being. Okay? That's not the same as me washing my hands and going, well, it's all up to you, nothing to do with me anymore. I still need to create an environment where they can find their ability to respond to their condition. Now, those domains of confidence, knowledge, and skills are the domains that make up a term called patient activation. Raise your hand if you've come across patient activation. Okay, a few people. So love it or loathe it. So the patient activation measure is a validated tool to measure people's confidence, knowledge, and skills to manage their health and their health care. And when you use the patient activation measure, it's a questionnaire, you feed in the results into a spreadsheet, and what that spits out is are two metrics. One is a percentage score, that's how activated someone is, and that corresponds to a particular level. Level 1, where someone is low in the confidence, knowledge, and skills, all the way up through levels 2, 3, and 4, when someone is really high in their confidence, knowledge, and skills to manage their health and their healthcare. And it's a little bit like this, okay? Activation, unless you measure it, is really difficult to observe because it's quite hidden. Now, I don't know much about gardening, okay? But if I was wanting to plant a fruit tree that would bear really good fruit in a couple of years' time, and I wrote into Gardener's World, and I got a letter back from Monty Don, he would probably say, Tim, if you want really good fruit in a couple of years' time, what you need to do is pay attention to the roots, because everything that you see above the ground, everything you see, the flowers, the foliage, the fruit, all depends on what goes on below the ground. And what we have in healthcare at the moment, the things that we routinely, especially as GPs, we routinely measure are the fruit of the trees, the outputs, the outcomes. So we'll measure things like medication adherence, care experience. We'll measure people's BMI, their blood pressure, their HbA1c. We'll measure unplanned admissions. And we'll measure A&E attendance, and we'll often get a letter from the CCG or someone saying, look, here's 6 months worth of money, can you reduce A&E admissions, please, over the 6 months? It's not recurring funding, okay, it's just for this period of time. Well, if you know anything about fruit trees, you don't get fruit in 6 months, you get fruit in 2 years. So you can do a whole lot of work, but actually, if the only way you're going to judge that is what's happened in 6 months, you'll be missing the bigger picture. So what are the roots of the tree? Well, we'd say that maybe the fruits of the tree are the confidence and the knowledge and the skills. Okay, so if you want really good fruit in a couple of years' time, that's what you need to pay attention to. Now, let's go back to our measure, the patient activation measure. Remember, I said it was a continuum. I said that corresponded to a PAM level. So people at level 1 are feeling overwhelmed and disengaged. As far as they are concerned, their health is yours to sort out. And we need to be careful here, okay, because we can think, oh, well, they're just not bothered. But often the case with people who are more low activation is that they are so overwhelmed with other aspects of life, okay? They may be trying to work 2 or 3 jobs to make ends meet, okay? They may be trying to pay the bills. They might have elderly parents. They might have young children. There might be a whole load of competing priorities, which means health is way down there. So people at level 1, overwhelmed and disengaged. People at level 2, they're becoming aware that they've got a role to play, but they don't know really where to start. And people at level 2, it can sometimes feel a bit precarious, a bit anxiety-provoking, because at level 1, it was all up to you. At level 2, I'm thinking, oh my goodness, I thought it was for you to sort out, but now I realize I've got to do something. That can feel quite anxiety-provoking. People at level 3 are starting to take some action. Okay, they're starting to change their behavior. Think about their behavior and change it. And people at level 4 are maintaining their behaviors and they are pushing further. Okay, people at level 4 are your self-managers. Okay, now I'm aware that although the patient activation measure is available in Sheffield, not everyone is using it. And so what you could do, Ollie Hart, my colleague in Peak Health Coaching, is also a GP in Sheffield, and I'll talk about him a bit more in a moment. He has an unvalidated question, okay? It's not as good as a validated questionnaire, but an unvalidated question. What he asks is this: what are you doing to look after your health? That's the question he asks his patients. And if the patient turns around and says, well, that's your job, you know where they are. All right? If they say, well, do you know what? I know I should, but I don't know really where to start, you know where they are. If someone says, well, do you know what? I'm quite good during the week. I tend to fall off the wagon at the weekend, so I do try some things, but I'm not that consistent, you know where they are. If someone says, well, I fast twice a week on a low-carb diet and I put all my cycle rides on Strava, you know where they are. There are not many of those, apart from Ollie, maybe. Okay. So how do we support great health and well-being? Well, we know it's not just about health considerations. We do have this well mapped out, though, don't we? And I know Charlie earlier was talking about maybe how we can maybe reimagine this and think how these boundaries might blur. So there's primary, secondary, community care, mental health services. We also know there are social considerations, social care, voluntary sector, community assets. They play a part. And also, we've just heard, There is this self-care bit, okay, where we have people who are, when they are making their contribution, they are coping, they're capable, they are more highly activated. Okay, but all of those three circles, they're not making the same contribution, okay, making different contributions. So in an acute care model, the healthcare sector is making the biggest contribution, okay? The circle is much bigger. The bit that, and that's because when we get injured, when we have infection, cancer, inflammation, mental health crisis, we need the health service to kick in, don't we? But actually, the social bit is not unimportant, but it's less so. And what we can do for ourselves in those circumstances is also less so it contributes less. Because what we need is the health service to diagnose, advise, treat, and mobilize resources. That's what we need. And perhaps what the practitioner knows, not just the doctor, but what maybe the practitioner knows is maybe in that situation, that's maybe more important. But let's look at the long-term care model. Okay, because that is the vast majority of the stuff that we do in the health service. And what we know in terms of outcomes, the health sector, what it contributes is significantly less. All right, we've heard a lot of stuff today. We still contribute, all right? It's not that we are irrelevant. There's a whole lot of stuff that I've heard today which sounds really good. I'm really looking forward to intelligent LFTs, absolutely. And we've heard about NAFLD, vascular disease, COPD, asthma, chronic pain, chronic mental health, cancer pain. But the social aspect contributes far more when we're talking about the long-term model. So we're looking at the wider determinants of health. Again, we've heard that today, haven't we? People's housing, their work, their connections, finances, access to facilities, and social care. And then, of course, the self. Right? The person themselves makes the biggest contribution in the long-term model, where people is much more dependent on their confidence and their knowledge and their skills to self-manage. That is what makes the biggest contribution. And that is about 50 to 70% of the NHS work. So that's the bit that we probably need to get right. So my question is, are we using the right model? So what the practitioner knows, perhaps in this situation, is less important. So let's think, actually, is this all down to us, or do we have some other people? Well, in general practice now, we have these additional roles. You may not be aware of them, okay? But lots of networks now are employing people to do some of these roles where we can increase we can help people support themselves. So we have health and well-being coaches. They are the people that help people understand what's the contribution that they can make. And then to think about what's their current situation, what's the situation they want, and work out steps that they can take towards it, even if those are really small steps. Okay, so we have health and well-being coaches who can do that work. We have social prescribing link workers, okay, who link people with particular conditions, particular needs to what's available in the community. Social prescribing link workers who are doing a really good job, not only link people to what's already going on, but what they do is they identify the gaps. Okay, they kind of think, well, what is it that this person particularly needs? What is the thing that's going to be most useful to you and what's going to be most meaningful to you? And then they kind of co-create that. And I had an experience of that working in my surgery with people with persistent pain, which is some of my background. And what they came up with was a swim group. Okay, for people with persistent pain, lots of people had never been near a swimming pool for years. But they went to the swim group, and actually during the period of time when they were at the swim group, and all of those months in between, I hardly saw them because they were doing stuff for themselves. Once that tiny bit of money ran out, they sometimes drifted back, okay, because they were not able to do that. So small things, inexpensive things, can make a massive difference. We have care coordinators who can help the people with the most complex needs. Okay, so those people with maybe multiple conditions where they're wanting to kind of navigate the contribution they can make, the contribution the social system can make, and also the healthcare system. Okay, so we have care coordinators as well, so it doesn't have to be all down to us. And if we get this right, then what we can do is create an environment where people become a resource to the system. Because they're empowered not only to look after themselves, but maybe look after other people who are a little bit like them. So they can become peer mentors, they can become health champions, they can be health trainers. So that's what we want, ideally, is to grow the assets in the community. And that's what I think will maybe create a sustainable service. I was doing some work with a network in Sheffield, and to come up with a mission statement. And part of their mission statement was they wanted primary care to be a happy and sustainable place to work. And they also wanted their population to feel empowered to look after their own health and well-being. My reflection was, general practice will never be a sustainable place to work until people feel empowered to look after their own health and well-being. And that's the bit where we need to invest. That's the bit where we need to put our energy and our resources into building up people's resilience in the community. And let me give you just a practical example of how this has been used in practice. So this is work that Dr. Ollie Hart did at his surgery in the Sloan Medical Centre in Sheffield. And what he did with this is patients with diabetes, but it's applicable, I think, across the board. He looked at that activation level, okay? Got all of his patients with diabetes to fill in an activation questionnaire, and then he worked out whether they were highly activated, levels 3 and 4, or more low activations, levels 1 and 2. And then he looked at their medical complexity, as is how well controlled was their diabetes. Okay, if it's really well controlled, they were not very complex. If their diabetes was out of control, then he classified them as complex. And then he thought, well, maybe we can do a different thing with these people. We can use a different intervention. So these people up here, they are low in complexity. Diabetes is fine at the moment, but they're also highly activated. And what he thought for those people, they don't need us. What they need is supported self-management, okay? So actually he could leave those people alone. He could send them a letter and say, you're doing really well, the numbers all look good, keep going. Here's maybe some websites that you might want to look at, but you don't need to come and see the nurse this year, like you have done every single year. These people who are more highly complex, but they are more highly activated, okay? So their diabetes is not well controlled, but they're ready for that conversation, okay, because they're more highly activated. What he would say for those people, they are ideal for the health and the social care sector. In primary care, we can do our best work with this group. So they will come in for their annual review as normal, and they'll be up for it. These people here, they are highly complex. Their diabetes is not well controlled, but they are also low in activation. Okay, low in their confidence and knowledge and skills. So for these people, it's not that they ignored their numbers and their diabetes, okay, they were safe, but actually for these people, because they are easily overwhelmed, okay, what they'll probably do well with for this group is actually to spend some time maybe with a health and well-being coach or the care coordinator or social prescribing link worker, at least in the first instance, so they can build up their confidence, their knowledge and their skills in order to then be able to engage in their health. And just a word, I mean, some of the nurses at my practice previously, they said, Tim, we get hoarse at the end of the day. We've been talking about oily fish to people, and they don't want to hear about oily fish, and yet I've been talking about oily fish until I'm blue in the face. And it's a complete waste of time, all right? Not that eating oily fish is a waste of time, but talking about it to people who are not ready to hear it is a waste of time. So these people here, they are low in complexity, their diabetes is well controlled, and the problem with them is because their diabetes is well controlled, they are easily missed. But they're low in activation. So we do nothing with them, then the chances are they're going to progress to be more medically complex because they're not doing anything to look after themselves. So again, these people will do really well with some lifestyle support, the health and well-being coach, the social prescribing link worker. We risk over-treating this group of people because they don't need us. And you know, when we've got really stretched resources and time and energy, let's not spend it on people who don't need us. Okay, so this clearly identifies people who don't need us. These people risk over-treating because they're not ready for us. So we can do our best work with this group. And this group will probably do better with someone else first rather than a medical professional. And this group of people we can leave alone. Wasn't that good? And so when he looked at the numbers, he found that that was a quarter of his patients with diabetes. He didn't have to get into the surgery, apart from doing the bloods and the foot checks and all that kind of stuff. All right? But he didn't have to come and see the nurse for their 20-minute, half-an-hour review. And what that meant was because the nurses who were previously trying to see 100% of the patients, they only had to see 50% of the patients, and therefore they could see them for longer. They could see people for longer with the people that they could do the most with. What difference do you think that made to the life of a nurse? Okay, they're actually doing nursing. And this group of people we can easily identify as people who will be better somewhere else first. Now, it's not just us saying about this. There's obviously this personalised care agenda. This is what's coming out of NHS England. And we can see here, and this won't be unfamiliar, so rather than having this patient with symptoms, we're seeing the whole person. Rather than asking what's the matter with you, we're asking what matters to you. And rather than this one-size-fits-all, we're shifting to this more choice and control and being a bit more intelligent in terms of how we're using our resources. Now, I did talk about coaching at the beginning, but before I talk about coaching, as we're coming to a close, let me just ask you who this is. Does anyone know who that is? Apologies for the poor quality of the photo. I was a long way away when I took that from the internet. No one? Okay, if I put him in context, does that help? It's Jessica Ennis-Hill, yeah, okay, and that is her coach, Tony Minicello. And the reason you don't know who Tony Minicello is, even if you know who Jessica Ennis-Hill is because at no point during the 2012 Olympic Games did he turn around to Jess and say, Jess, take the weight off, I've got this one. Okay? He didn't do any of that. Jessica Ennis-Hill won her gold medal by running fast and jumping high and jumping long and throwing things. That's how she won to be the best in the world. Her coach, Tony, stood in the sidelines, encouraging, supporting, and maybe very occasionally giving some advice. Now, I don't know about you, but it sometimes feels like I'm the one. Okay, he's jumping high, okay, running fast, jumping long, and sometimes throwing things in frustrations, while my patients sit on the sidelines, sometimes encouraging, sometimes supporting, and sometimes telling me how I might be able to do it a little bit better. And so I hope you'll agree with me that there's something wrong with that picture. Okay, now I don't think you can make someone run their own race. Okay, but I do think you can coach them onto the track. But the other thing that needs to happen, if you want to coach someone to the track, the other thing that needs to happen is that we need to take a step off the track. And we are so used to running the race. We are so used to running the race and dragging our patients behind us, kicking and screaming, okay, whether they like it or not. Okay, and actually it's exhausting, and it's not sustainable, and it's not manageable, and it's just not the right thing. So we need a shift in our perspective. Now, it's not that I want us to kind of go, because we have all this health expertise. I'm not saying, please forget that, forget all your training. I'm not saying that. What I'm saying is use your training, use everything that's working well, but maybe layer on it this health coaching, maybe mindset, which is coaching skills, tools, models, maybe some goal setting. We could learn some of that. It wouldn't take long for us to do that. Behavior change, awareness raising. And the health coaching bit is this bit that sits in the middle. Okay, so it's not instead of what you're already doing. And someone challenged me, what's your definition of health coaching? And I think it's this, that health coaching is providing exactly the right environment for people to think really well about their health and well-being. Okay, when people think really well for themselves about their health and well-being with the right information, they will probably make really good choices if we trust them to do it. So there's a lady called Nancy Klein who says this, that the quality of everything we do depends on the quality of the thinking that we do first. The quality of everything we do depends on the quality of the thinking that we do first. So if we want our patients to do quality things, we need to provide an environment where they can think really well. And it might not be that we've got the time to do that in our precious time that we've got, but there are other people in the system who can maybe help us with that. And I think, in contrast to the doctor knowing best, I think this is more accurate, that people know what is best for themselves given the right environment to think brilliantly. And I think that involves, as well, giving them the right information in the right way that they can grasp. That's what I think. All right? So it's not that we can abdicate responsibility. So I think, in conclusion, we need a new mindset. Okay, so the patient needs a different mindset, which is that they've got a contribution to make. And actually, when we look at the data in terms of long-term outcomes, the steepest rise in terms of improvements is moving patients from, this is nothing to do with me, to I've got a role to play. And their behavior's not changed, by the way. All right? The only thing that's changed is their mindset. Nothing to do with me, to I've got a role to play. And there's people in the system that can help people make that move. So that needs to happen, but I think we also need a change in mindset for ourselves as well, because what we're doing at the moment is not sustainable. And suppose what I would like you to do is think, next time you've got a patient in front of you, think about asking yourself this question. So if I knew that the person in front of me has the most important contribution to make, how can I support them to make it? And ask yourself that question. And if I can't do it, then who can? To be thinking about that. Now, I know there's a popularly kind of quoted statistic here that people with long-term conditions use about 4 hours of healthcare professional time in a year. Okay, that leaves 8,756 hours where they are self-managing. So if we don't do anything during our 4 hours, which in some way supports them for the other 8,756, then I think we are missing a trick. Thank you.
That was absolutely fantastic. What a great way to end the meeting. So before we close, I'll just remind those of you that if you want your CPD certificate, please, on the website, fill out the forms of your feedback, and then you can get the certificate from there. Coming back to Tim's analogy of the tree, when you're at a meeting like this, the things you don't see are the fact that to my right are Stream 7, who just run the thing, make the show work. If you're watching on the website, then it's Creative Stream, who have always worked with us and just are brilliant. The people in the hotel that we have such a long-standing affiliation with and we're very fond of in the Crown Plaza. And of course, Falk, who have recurrently helped and supported Sheffield Gastroenterology and looked after our meetings. So finally, I want to thank all the speakers. Thank you so much. I want to thank all the delegates who've come or have watched online. Have a lovely weekend. This is Sheffield Gastroenterology. Thank you.